and this has been a big year. So I think that we have been offered an amazing opportunity to do this virtual symposium. Again, my name is Kathy, and I'm a board member. And the mission of Connect Summit County is to create a well-informed, stigma-free community with access to mental health resources for everyone. And in order to meet this mission, we must talk about mental health and look for solutions that are tailored to the individual, not the system. That's why I'm really excited to learn from our experts today. Before we begin, I'm going to turn it. Betty, do you feel like you went over the Zoom etiquette and we can jump in? Okay. So Betty's gone over that, and we're going to introduce our panel, which is really exciting. We have Dr. Kendrick, who is a lead ketamine expert at the University of Utah. And I'm really excited to learn about this because I don't know a lot about it. We also have our very own Dr. Melissa, who is a child, adolescent, and adult integrative, and that's going to be an important word through this discussion, psychiatrist in Park City. We have Matt Mishkind, who is a Ph.D., and he is the Director of Military and Veteran Programs at the Helen and Arthur E. Johnson Depression Center at the University of Colorado. So very excited to hear about some of the things he's working on, which have to do with technology and mental health. And again, one of our very own, Jen Solomon. She's a certified trauma-sensitive yoga teacher and health counselor. And she's certified in meditation and mindfulness as a teacher. So I'd like to start by just asking each one of our panels to tell us in 2 or 3 minutes a little bit about what you're doing that's innovative, and just start the discussion with letting us know what you're doing. And let's start with Dr. Kendrick.
Excellent. Well, I'm so excited to have the opportunity to be here on the panel today. As was mentioned, I'm currently practicing psychiatry at the recently dubbed Huntsman Mental Health Institute at the University of Utah. And I work in our treatment-resistant mood disorders clinic, a clinic that was established to really help with the upwards of 30 to 40% of individuals who may not respond to first or second line treatments for depression. And as part of that clinic, amongst a lot of other treatments that are offered, we recognized about 5 to 6 years ago a very promising treatment in utilizing ketamine for the treatment of depression. There's a long-standing literature and evidence base for its efficacy in depression. And despite the fact that at the time there was no FDA approval, we thought that getting that treatment out to patients in a safe and responsible way was important. And that was the basis for our clinic. Since that time, an FDA-approved form of the drug has become available, and we've evolved somewhat in our practice. But it's just exciting to be in a place where we have the opportunity to work with patients that have tried a lot of different treatments for their mental health without having the response they're looking for, and to be able to offer some hope in those situations is really rewarding. So really grateful to be here. Appreciate it.
Thank you so much. Dr. Melissa, let's hear a little bit about what you're doing.
Well, as you mentioned, actually, thank you so much for hosting this. I think this is the Utah State of Mind is just a great forum, and I'm so honored to be a part of it because I think it's such an important discussion that we're all having at this timely hour. I think we're all know that there's increased need recently over the past year, and so, and I'll talk about what our clinic has done to kind of meet those increased demands. But in general, I'm a child, adolescent, adult psychiatrist. I do a lot of integrative psychiatry, which means I weave in a lot of complementary, more holistic mind-body approaches. I teach a lot of meditation. I focus on exercise, diet, sleep. So some of these kind of core things that I think are helpful to build overall resiliency for individuals. I have a lot of experience with utilizing supplements in addition to medication. So I've really tried to kind of look at the whole person and try to figure out what are the best, what we call entry points to care. And I think, part of this discussion and part of why I'm so happy to be here is over the past year, our clinic has been evolving to figure out what can we do differently to provide the ability for more people to access mental health. And that could be anything from, hey, let's take a meditation class all the way up to, ketamine treatment, or maybe it's yoga, or maybe it's, individual therapy, and what kind of therapies are that. So we've opened up so some of the things we've done in our clinic this year, we've opened up a new TMS clinic, which is a transcranial magnetic stimulation clinic, to provide that additional novel intervention to the Wasatch back. And that is a really cool treatment. That's a non-medication based treatment for depression, PTSD, addiction, and so forth. We've also been running some parent program groups, so helping parents help their kids. We've also been, we're starting what we call our Z Changer group, which is going to be starting in 2 weeks, which is really focused on teaching our teens and tweens leadership skills, resiliency skills, and service. And so monthly we'll be doing service projects in the community to help kids learn how to help others, to get themselves out of themselves and into the community. And then we're developing an app, which I'm not sure how that's going to turn out with apps nowadays. We've been creating a lot of webinars that people can have access to, that, if they don't have access to me, or they can't get in to see Dr. Kendrick, or they can't see another therapist because everybody's booked up. There's some other programs we're trying to develop to support people until they can get in to see somebody like myself. So that's kind of what we're doing at our clinic. But again, I wanted just to thank you guys for inviting me here, and I'm excited for the communication and what we're going to talk about next.
You're doing a lot. I'm really excited to hear more about it. So how about Matt? Why don't you share with us what you're working on? I was really intrigued on our call that we had before when we were planning this.
Yeah, sure. Thanks. I'm looking at the chat. I think I'm the only Colorado representative so far. So somebody else, if you're from Colorado, you have to chat it out there. So I'm over in Colorado. I'm at the Anschutz Medical Campus. I run a couple different clinics and a center over here. And in terms of innovative, we used to do innovative stuff called telehealth, which now I don't think people consider innovative anymore. But we like to say that we were doing about 30% telehealth before COVID. So that was something we always had. The issue with telehealth is it's still a one-on-one connection, or a one-to-one connection. And what we've seen, and I'm sure others have seen this, is calls to our clinics are up maybe 30% or more from pre-COVID. And there's a good and bad story here. Our cancellations are down and our no-shows are down, which is great because that gives access to care, but it's adding a huge burden on our providers, on an already burdened system. So we're starting to see, some burnout with providers. I think they're really starting to feel the brunt of it. And interestingly, my bias is mental health hasn't gotten sort of its share of healthcare focus. Now it does. And so now everybody's like, oh, mental health, right? And so you have this already burdened system, and now everybody is getting more and more. So what we're starting to do, and I'm interested to hear what others are doing too, is we've actually started to do a lot more training as well to try to get community members more informed about mental health and see how people can help each other and see where we can get some services out that don't have to come into a clinic. We've also done some work with apps, and one of the things, we haven't implemented it yet, so I'll put that out there, but we're really trying to look at these what's called computerized CBT or guided computerized CBT type programs, because the research out there, I was actually just looking, there is a new, I can hold it up for everybody, but in JAMA Psychiatry in January, a new article came out looking at as a meta-analysis on computerized CBT for depression, and just showing the effectiveness of it. And what we're seeing is the outcomes are equivalent for, there's always a caveats in there, but there are equivalent outcomes. But the beauty of it is, if it's a guided computerized CBT, a provider needs to touch base with the patient maybe every 3 or 4 sort of modules, or what you might refer to as sessions. So you're sort of taking that 1-to-1 relationship and maybe making it a 1-to-4, 1-to-3, 1-to-4 relationship. So that's really a way that you can actually start to provide expanded access from a sort of like a group perspective. Not just telehealth can give you access to people who don't have access, and so you might get some geographic access. what we're seeing is this might actually provide more population access. So it's something that we're starting to look into. Like I said, we haven't implemented it yet. I think that up until relatively recently, the research was there, but I think now what we have is the research is really there, and I think you have a lot of these programs that are kind of prime time. So I'll talk more about that during. I realize I'm starting to talk more. So
no, it's excellent
right?
because we're going to talk specifically
yeah.
about that. You know, how we can provide more treatment. So
Yeah.
that fits in perfectly.
Okay.
So
I'll zip it for now, and then I'll.
Well, hold it. Don't zip it. Yeah. Jen, let us know about what you're doing.
I am Jen Solomon. I am a trauma yoga specialist and an Ayurvedic health counselor. Super excited to be on this panel. What we do in trauma yoga therapy, we deal specifically with PTSD, but most of what we deal with is complex trauma. And there's a difference between PTSD and complex trauma, and that PTSD is diagnosed as a one instance, one-off, whereas complex trauma is relational and ongoing, and typically has some form of what we call captivity, which is kind of a problematic word. But if you're thinking about ways, like being in jail, for example, is a form of complex trauma, in that you've lost your autonomy. You're told when to get up, when to go to sleep, who can come visit you. You can't make decisions for yourself. It's ongoing and exists in the context of a relationship. If we apply that same idea, then being hospitalized for a long-term illness is also complex trauma, just as domestic violence can be complex trauma, or childhood trauma as complex trauma. So what we do in trauma yoga therapy, it's called bottom-up processing, whereas talk therapy is top-down processing. Trauma is a body response, and it's oftentimes the body being stuck in a stress cycle. When it comes to the brain is kind of waiting for the body to tell the brain through what we call afferent nerve fibers to the vagus nerve that the threat is over, and that we can switch nervous systems and we can go into rest, digest, and restore. And so we just bring the body back into practice. So we use a lot of choice-making options in our yoga. We use a lot of interoceptive body cueing, and we'll talk, I'm sure, at some point about what that means. And then we use this idea of pendulation and titration. And pendulation and titration is moving the body in a repetitive way, which kind of works through a stress cycle on its own. And then titration is where we bring attention to certain parts of the body at a time. Like as we're doing this movement, you know, can you feel your big toe? Can you feel your right thumb? So a little bit of body awareness, which is present moment now awareness, which can often stop a panic attack or a stress cycle in its tracks. And so that is what I do. I work specifically with other talk therapists. When you're dealing with body practices, we want to make sure that we have a client who's in a good place to come back into their body. Everybody I work with has a trauma therapist or has a talk therapist, and I work with a group to provide services as they see fit for their clients.
Thank you. I'm going to jump right in with a question that everybody can contribute. When we're working with individuals, I look at it, it's like a puzzle, and we're putting different pieces of a puzzle together. And Jen said something really interesting when we met before this panel, that what she does is not a standalone therapy. It's part of a process and part of a treatment plan. And I am really interested if each of you can tell us your part in a treatment plan. And just for sake of continuity, we can all be working on the same client. And this would be a client that has PTSD, is a veteran, and is suffering with depression and possibly access to services. So I'm curious how each of you would address an individual like that and work together on a continuum of care. And anyone who feels they're ready to jump in can jump in.
Well, since I got to do the first introduction, I'll jump in real quick with my part of this. This is a great case example of why a multidisciplinary team is really important. My expertise and area is really in treatment refractory mood disorders. And we oftentimes will have patients come to our clinic and present for a consultation, and it becomes very apparent that trauma or some other psychosocial component of their lives or other aspect is really affecting the underlying depression. And so I think a really important point is to recognize what the factors are that contribute to a depression. Depression is a comorbid illness amongst any number of other mental health conditions. And so in my clinic, what my goal is to recognize what are the biological factors that might be responsive to the treatments that we have available in our clinic, but not to say this is going to fix all of your problems, and to really help this patient have access to the probably arguably more important aspect of their care, which is really good, well-informed, trauma-focused therapies. And so, I think that's where a treatment plan starts is, these patients will end up with a single point of contact often, whether it's their primary care provider or an outpatient therapist or somebody, and having an individual as part of your treatment team that's willing to connect and network with other experts in other fields to give comprehensive care, I think is just so important.
Thank you so much. And, something I'll just throw, oftentimes this is insurance driven. So it's hard to really, we can't bill for, collaboration, which is really a shame. But I feel like if we do a good job with this, then maybe we can later, lobby that. So anybody else want to talk about how they would start with a client like this and work together? Go ahead, Dr. Melissa.
So usually when I see a patient or client, the first thing I want to know is the severity of the issue. And then I want to know where they're at. What are they willing to do? What would they buy into as far as their treatment? And if it's say it's mild PTSD, perhaps starting with maybe a little bit of EMDR, maybe some therapy, maybe a couple supplements to help them sleep might be a great place to start. And then I'll say, hey, so what do you think about these options? And then, you want to make sure that they buy into whatever you recommend. Now, say we have somebody on the more severe spectrum, they have very severe PTSD, that, they're not sleeping, they're having constant flashbacks. Well, then I'm thinking we got to go a little bit more aggressive. We got to have a little more, biologically based treatments, ketamine, TMS, maybe some medications, in addition to what I'd mentioned for the mild issues. And then in addition to maybe focusing on, sending them to Jen Solomon, say, hey, I have this person who's really struggling. They have a lot of physical symptoms. Let's, do some EMDR work, maybe some TMS, maybe a little bit of medication and some yoga all together. Like when I have people who have pretty moderate to severe issues, I do the full court press is what I like to call it. But I do the full court press based on what the person will buy into, because not everybody is going to be okay with doing meditation. Not everybody is going to be on board with doing my exercise program. Not everybody's going to be, yes, I'm going to do ketamine or I'm going to do TMS. So we really, I always have to stress, we have to meet people where they're at, what they're willing to do, and then start there and build your holistic program around that. And that often includes multiple treaters in multiple settings for people who are really struggling.
Thank you.
Yeah, if I can piggyback on Dr. Larson, I think that start where you are is a really important thing when we're working with trauma yoga therapy specifically. We need to start where our clients are presenting at that moment in time. So if, I had a referral from Dr. Larson, for example, for this client, we would have an intake form that's very specific about what will you buy into? What parts of your body are off limits? What things are we just not going to do? What things are we not going to talk about? And we stick with that intake form. We stick with that as the guideline. And then, whatever's coming, whatever's presenting that day is what we deal with in trauma therapy. It is movement. For some clients, meditation is contraindicated depending on their level of trauma or what has happened with their trauma. A lot of clients respond much stronger to fast movement in the beginning because, we are in a heightened nervous system arousal. And so taking someone who's in a heightened nervous system arousal or a sympathetic nervous system arousal, and then saying, okay, relax, it's not going to work. And then the relaxation can trigger another trauma response, especially if you've had someone who has been in a relaxed state and then something traumatic has happened. That sensation of relaxing can then kick in another sympathetic response. So we want to be in a way of meeting our clients where they are. Sorry, there's a bit of echo, so I'm losing my train of thought. So we want to be where our clients are. If they're in a state of arousal, we want to move them in a faster way and then work on bringing them down from there. If they're in a low state of arousal, we want to move them in a slower way and then work on bringing their nervous system back up to regulation that way, if that makes sense.
Great job mastering the technology little blip that we had. For everybody, we have something going on with internet in the Park City area, so it's a little wonky right now. Thank you so much for that. Okay.
Really quickly, sorry. Yeah. So I, as a community member, am not quite sure all of the amazing, very technical terms that are being used. So if you can help me as a community understand acronyms and some of the technical terminology, this would be that would be really, really helpful because I want to understand fully.
Excellent. Okay, Matt.
Yeah, I mean, a lot of the same things people have talked about, but I think one of the things that we do try to do, and it makes our front desk and probably intake coordinators not happy with us, is we encourage people to call us even if we can't see them, because we know too often people call and just get the sort of the dead end. So one of the things we would try to do is figure out where somebody is best fit. And it doesn't, we also have this mentality that we're not here to hold on to patients. There's enough people. And so we want to make sure that when people come through, we'll do some assessments, we'll talk to folks and really see if we're the best fit. I mean, our clinics, you know, we have a much more of a traditional, even though we're trying to do these different sort of technologies, we have a very traditional focus of evidence-based practice, you know, so we'll follow, you know, we'll do PE, prolonged exposure, EMDR, eye movement desensitization, and then I always forget the R, and then ACT, which is acceptance and commitment therapy. You know, that would sort of be for, if somebody was coming to us with trauma, that would sort of be our first focus. We know that not everybody is going to be the best fit. We know that sometimes people are going to need to do, you know, something else and then come back to us. We also have integrated psychiatrists, so then we'd work with our psychiatric teams as well. And I think one of the things we've really started to do as well is, you know, and I don't think we would send somebody out to necessarily do like crystal therapy, right? That probably wouldn't be something we would send folks out to do. But, you know, we also believe in this, there's so many different ways that people can get help today's world that's non-clinical. And so that's something we're really trying to figure out too, is how do we really work with somebody? Hey, if they feel like they're doing something and it's helpful for them, that's great. And we're not going to stop that. We have beliefs on what our model is and things clinically that we think are effective. But if somebody's doing something else and that's helpful, then we're going to try and work with that as well. And we're not going to tell somebody not to go do crystal therapy, but we're going to probably say like, why don't you do this with that as well? And things like that. So, you know, that's part of that integrated stuff too, is really looking out there and saying, you know, we know that there's research. We know that there's places where there's research that's developing, and some places there isn't research, but, you know, we try not to be so necessarily arrogant about everything that we would say, if you feel it's helpful, then let's work with that, right? Let's not overtake that. Let's not have that be the only, but let's work with that. So I think that's another place where we try to be integrative.
I love that. And everybody's saying, you know, start where the client is. And one of the things that we have found out with our state of mind survey is that often when an individual is struggling, they don't know where to go or how to access services. So I'm curious how you all are reaching out to the community and learning about each other also and what your colleagues are doing, so we can put together this sort of treatment team and continuum of care. So the first question is just access. How are people finding out about what you all are doing?
You know, and I think others have talked about this. We do a lot of community events and a lot of community training. And one of the things that we found as well is that people are not as well educated about mental health in general, but especially about all the different degrees and certifications and license out there. So we actually do a lot of work too of just explaining to people, hey, this is what, if somebody has LCSW after their name, this is what that is. If somebody has a Ph.D. versus a PsyD, PSYD, this is what the two of them are. Here's where you might want to touch base with somebody. So it's really just kind of getting people educated, because, you know, so often we'll get, if it's friends, family, just neighbors, anybody who I'm talking to, they're so confused by all the different terminologies in mental health. Like, a lot of people don't understand the difference between a therapist, a psychotherapist, a psychologist, a psychiatrist. And I think too often people just kind of make the first call and don't know all the options that they have available and who to go to for what kind of a situation and who might be best for them in a certain situation. So we really try to do just a lot of community outreach. You know, we have an annual fundraiser every year where we bring in tons of people and just do talks and really just try to get that information out there, because really it helps the whole system. It helps the person seeking care, but it also helps the providers in figuring out ways that you can accept people that are best fit for you and also find those referral pathways.
I think that's a great point, and piggybacking on that, one of the things, as was mentioned earlier, insurance is such an integral part of healthcare for a lot of our patients. One of the things we'll often try to do is have one of our coordinators in our clinic work with the patient on their existing panel of covered providers to try and help match that, so that the financial piece does not become a major constraint. We do enjoy a little bit of a benefit of being at a university academic setting, and so people tend to kind of come there. But we also are fairly limited oftentimes in our resources and the ability to see the number of patients that come to us, and so we really do try to learn about all of the equally great providers out in the community that are out there working to help get patients access sooner and earlier. There's no reason they should just wait to see somebody at the university when we've got so many great providers in the community who provide great work.
Well, I'll just jump in. I think, you know, one of the things that we've been trying to do more regularly is to be more present on social media, because that's where people are. It's not something that I've been overly familiar with, and I've been learning a lot about it this year. So we're trying to promote things. We have somebody helping us kind of advertise more, not necessarily to, you know, because I need more patients, because, like, you know, most of us are kind of bursting at the rim, but really just to, you know, to let people know that we're here. We try to, you know, for every person that calls, we try to give them something, whether it be a referral, some type of service, whether, hey, no, we have this meditation course, or we have this webinar on PTSD while you're waiting to get in, or so we're trying to find ways to give them something in the moment so that they don't leave and say, and put their hands in the air and like, I give up. I've called everybody, nobody's calling me back, or nobody has any availability for 6 months. And so that's kind of some of the things that we've been trying to do, is just being more present on social media, asking, you know, or being part of these great programs throughout the community. And, you know, I do my best to really reach out to the local therapists when I have a shared client, just say, hey, we've not met, we've not worked before. Tell me a little bit about yourself. Tell me, you know, who do you like to see? Who is your special niche? And so I know moving forward, who the providers are that provide maybe CBT or certain types of therapies that I'm hoping for, or whether it be a trauma-focused yoga or those types of things.
Excellent. And of course, with Connect, that is one of our goals, is to have a, you know, an informed community about what's available. So it's just things like this that help. I was really excited to hear from Jen, because something that she said in our pre-panel talk is that she has some clients that she's working with that are in grants. And that really excited me, that there's a whole population that is accessing your service that's not coming through insurance.
No, we don't bill. I have a nonprofit that I work through, and I have a fantastic grant writer. And so that's how we're funded. So all of our clients, I mean the nonprofit, all of our clients have to come from a therapy referral. We don't work with someone in the trauma field, in the body-based trauma field, that doesn't have a current talk therapist. I just feel that that piece is so integral, because we don't cognitively process, we body process. We just work directly with the body. And I can't hold space for you, and I can't counsel you. That is not my wheelhouse. That's not what I do. I'm a yoga therapist. I'm not a talk therapist. So if you come with a referral from a therapist, either that I know or that I can know, it is a fee-free service, and we will set up weekly services. Some of our sessions, depending on where you are 15-minute sessions. Some of our sessions are much longer. So there's kind of a looseness to it in the body realm of, you know, where you are, what's coming up for you today, and where we can go safely, because what we don't want to do is break the container. And the container really needs to be strong before we start putting people back into their physical body who are living with trauma or living with complex trauma.
Excellent. Thank you all so much. And Betty, let me know when you want to open up, if there's any questions in the chat so far. Anything there? Nope. Okay, then we'll keep going. COVID, I'm curious, because the landscape has changed dramatically in a year, and you know, there are some silver linings with that change. And I'm wondering how each of you, what you've seen, you know, Matt, you were sort of on the cutting edge of technology. I'm sure it's boomed since COVID, what you're doing. And how, what's different? What's different in the landscape of what you're doing since we've experienced COVID and we're all on Zoom?
Well, everybody's getting sick of Zoom. That's one thing. Yeah, I know, you know, we've seen, again, going back to just if you want to just talk about telehealth. So our clinics are 100% virtual still. You know, and we're seeing groups, we're seeing individual therapy, psychiatry. You know, every now and then there's somebody who does need to come in, and so we sort of figure that out. But I think what we've seen and what the data suggests is where a lot of healthcare sectors saw some pretty significant decreases. Mental health saw a little tiny blip sort of when, like, middle of March last year. And then since then, we've seen a steady increase. And so I like to say to people that mental health is really, without mental health, without telehealth, without technology, we'd be doing a lot worse than we currently are. And I think mental health was really able to use technology to maintain services. Now, again, we're starting to see the other side of that in terms of much more demand for services. We are not, you know, we're not reproducing providers all that quickly. So, you know, we're starting to see sort of that. But I think in general, I think we're starting to see more focus on mental health. I think people are starting to rethink the need for mental health and the benefits of it. I think that we're going to see, as we move into the future, a much different landscape, because now I think people are becoming used to the fact that an hour, you know, session is an hour session. I don't have to drive somewhere. I don't have to sit in a waiting room. There's not this and that. And so I think we're seeing people who are getting used to that. And I think what we're also starting to see are people who over time are actually really desiring that in-person connection. And so some folks really do still want, some people love telehealth, and some people really still want that in-person connection. And so I think what we'll see, the silver lining, I think one of them is we'll see some regulations hopefully continue to change. And into the future, I think we'll see a healthcare system that doesn't say everybody has to come into a clinic. I think hopefully we'll see a healthcare system or a mental health system that says, we have these flexibilities, let's figure out what is the best fit for the patient and what's the best fit for the provider. Because on the other end, and I'll stop in a second, we found flexibilities for our providers too. You know, a lot of our providers are of the age where they either have kids or they have parents they're taking care of. They're sort of in that sandwich area. And for them, being able to have flexibility around when they meet with patients. You know, some people go pick up their kids at 3 o'clock, and then they get back on and do a session at 6 o'clock and then do some evening sessions, where if you're in that typical 9 to 5 clinic, you can't really do that as much. So I think we'll start to see hopefully a system that really provides care just where people are, both physically and emotionally, and how they want to get their services and how the provider wants to deliver it.
So true. And I'm really interested, if we have time later, in the cognitive behavioral therapy app that you're putting together, because it'd be interesting if the skill-based therapies could go more on an app, and then just the relationship is so important as well, just for change. So anybody else have some innovative and silver lining COVID?
I'll just jump in here and add, I think when we think through the mental health impact of COVID, we start with the burden of all of the changes we've all had to make, the effect that it's had on careers, jobs, parenting, the homeschooling, all these things. I think it's also, in addition, important to remember that we don't fully understand what the biological and physiological impacts of COVID are on mental health. There's a lot of thought and evolving study right now that the inflammatory response to COVID is affecting all the organ systems, including the brain. And so I think we're going to have to be ready to really evolve our practice to support, the biological, psychological, social components that this whole experience has really brought about.
It's an excellent point. As a COVID survivor, there are some interesting things I'm experiencing, like the brain fog, and it'll be interesting how that what we learn. I think we're just learning every day more and more. So that's a huge point, the biological piece. I know, Dr. Melissa, you have some exciting things happening with the app that you're creating. I'd love that perfect timing. Did you decide that before COVID, that this was a direction, or was it just a perfect storm?
Well, so when COVID first hit, I went primarily to telepsych. I was already doing about 1 or 2% telepsych for some individuals, but obviously I had to hurry up and move most of my patients over to the telepsych platform. Although I do see maybe about 20-30% of my patients now in person, because they really do. There's some people who really just can't, they don't do great on telehealth. But for the majority of the people who thought they wouldn't like it have actually really enjoyed it. And so that's been a nice perk. But I think, as I saw, my phone ringing off the hook over the past year, and I'm, feeling frustrated that I wasn't able to give people some services that they needed, like in the moment. I'm like, okay, so I got to rethink this, what I'm doing here, and figure out how I can reach more people, even if they can't see me. And so the app, basically what we've been doing is we've been doing a lot of videos and filming and just putting out a bunch of just free content, and we're putting it together on this app so people can access, okay, so I don't feel great today. What are some tools I can use? And I have on the app meditation, information about nutrition, different types of therapy people can explore. And so that, this is really just to give to people to say, hey, there are some resources here. And obviously I'd like to build it. It's going to be a pretty small, rollout, but it was really just to figure out how I can get people that support in the moment when they need it the most, because that's the piece that I think we're all unable, well, not maybe it's just me, but I feel sometimes I can't help people who are not my patient in the moment. And if I can't get them in for several weeks, then I want to give them, like I said, something to hold them over, that they're not alone, that they have some resources. We can give them some tools to try and practice, to hold them over, so to speak.
And just education. I think being able to push out the education piece around all these different modalities and treatment and the roadmap, which we try to do at Connect, to get help, is so important.
Exactly.
What about you, Jen? How, I'm curious, because it's such I don't know if you can do virtual trauma yoga. How is that working for you?
That's what we're doing currently. It was a little bit of a figuring out the startup, but you know, they've got Zoom in jail now, so they just Zoom me right in to jail, and I teach in there, and I Zoom right into the Peace House, and I teach there, and I Zoom right into the Summit County Recovery Foundation and teach there. And I've been able to see more clients because I have less travel time. And with one-on-one, it's been much easier because one-on-one movement therapy is really easy to do on Zoom. Groups are a little harder, especially if, you know, you've got like this, if I was trying to do a group yoga therapy class, like with all of us here. But one-on-one, it's particularly easy as long as we've got a strong Wi-Fi connection. You know, sometimes it goes down, sometimes it comes back up, but I don't have to travel in between clients. So I can schedule more in the same amount of time because I don't have the travel time. So
it's really maximizes time. It's so helpful.
yeah.
Excellent. Betty, are there some questions? You're the master of the chat room. So
Yes,
let us know what the questions are and we can kind of
some questions. It's awesome. First off, I just want to let everyone know that the name of the app that Dr. Melissa Lopez-Larson is called MindMend. That was one of our questions. We have a really great question from Wendy O'Leary. Do any of these modalities work well with persons who have schizophrenia or schizoaffective disorder?
I always like to jump in. I like to talk a lot, so I know everybody will have something to say here. The answer to that question is, yes. I think we traditionally think of schizoaffective or schizophrenia, these severe mental illnesses as being, primarily biologically based, and everybody really just gets focused on the biological interventions. But there's so much research out there that shows the benefit of this holistic approach. And so while I'm obviously a guy who focuses a lot on biology in my practice, I think you miss the mark if you don't have patients who have access to a lot of other types of therapies to treat even a severely biological illness.
And I could jump in too. I do have a lot of, well, shouldn't say a lot. I do have a handful of individuals with schizophrenia and schizoaffective in my practice. And in addition to prescribing medications, I work with the families to make sure that they get to their appointments on time, that we do some family-based kind of treatment to help support, their child or adolescent or older adult, whatever their age is. A lot of the medications can cause some weight gain. And so I'd work a lot about nutrition and exercise. And so I think that they all go hand in hand. You want to make sure people are sleeping. So all the same kind of treatments can be applied to just about everybody. But you do want to kind of do it in a holistic way and definitely get families involved for people who are really struggling with some of these kind of more severe mental health issues.
Amazing.
And I kind of call it, I think what we're talking about is therapy off the couch, with some of this integrative approach. It's, all this wellness concept that it is integrated, and there are so many different ways to address it depending on where the client is. But I am really excited that we're looking at this in a more broad way. Something I think that's interesting is family systems as well. This is not, and people are coming into a clinic or to get services, but there's a whole family system in the wake. And one of the things that connect that we really try to do is support that family system. And what I'm hearing from everybody on this panel is that that, and you're looking at that piece too, which is great.
Well, and I think just a tagline, and I think the more severe the issues are, I think the more supports in the community, families, et cetera. We need to pull in more things to kind of wrap around our patients when they're really struggling. If you're having some mild anxiety, you probably don't need all these different, services. But, as we go up on the severity or acuity of what's going on, the more systems we can engage, the better, whether it be school systems or employment opportunities, great groups like this, you know, there's NAMI, there's a lot of other ways we can help support people and their families to get back on track and continue on their kind of their wellness journey. And so I think all of these kind of techniques apply to just about everybody. All this idea that holistic stuff is only for the kind of the healthier people is not where we need to be going. We need this for everybody. And, you know, if we're getting everybody, you know, eating well, sleeping well, eating well, that, you know, their chances of relapses and reoccurrences of some of these issues is going to go down with healthy living.
We need insurance companies to recognize that, because I think that creates such a barrier. So I'm hoping that, you know, this time of COVID, that could be another silver lining, that there, you know, insurance companies are really looking at other ways or, you know, to support their clients.
Matt, you're doing an excellent job responding to people in the chat.
Yes. What are bring some of the other questions to the group, Betty.
Sweet. So one of our questions comes from Sally White. Do any of you find that some patients actually enjoy staying home? Some of my technical colleagues are delighted to isolate. And Matt answered, yes, that is something to watch clinically, especially if dealing with isolation or anxiety issues. So I'm curious if anyone else has anything to say about that, or Matt, if you want to expand.
Yeah, I mean, I think it is. I mean, there are certainly people, and you know, I have 3 kids, and they're all different. And like one of our kids was absolutely psyched when we went to homeschooling, and she also has anxiety issues. So, you know, go figure, right? So I think that's something you do have to watch for, is for people who are like, oh, this is awesome, right? I can stay at home. I don't have to go anywhere. And yeah, while we're given access to care, right, you have to kind of wonder like, okay, well, what's that doing, right? Because for some people, the simple act of coming to the office, dealing with travel, dealing with actually going to the front desk, right? I mean, we have people all the time who, I'll be in my office at work, and we know we all do it, and suddenly somebody pops by who's, you know, a client to ask me a question. Now I know that the therapist has said to them, we're going to go ask somebody a question because that is part of the treatment. So I think that is something, you know, you have to constantly look for. You know, I've seen more and more, what I've started to see now are people who are, if they're having trouble with clients who really do like that isolation and they can't meet them at the clinic, you're starting to see some providers meet outside and go for walks and do certain things, one, to have that face-to-face connection, but also just to get the exposures out there. So yeah, so you do have to look for that. And I've also heard, and I don't know if anybody else has heard this, anecdotally, we're hearing, especially from kids, that kids are actually much more willing these days to go into sort of intensive outpatient programs or even partial hospital programs, because on the reverse side, we're hearing kids who are like, so my option is to stay at home, do school from home, be around my parents all day, be at home. Did I mention be at home, right? And have no, or I can actually go and do this intensive group therapy. And, or kids would be anti doing that. Now we're starting to see some kids be like, that sounds good to me, right? Because that's almost in some ways their only socialization at this point. So we've actually started to see somewhat of a reverse occur that we hadn't seen before.
Yeah, I think this is really interesting. I was talking on a podcast the other day between the difference between social anxiety and being an introvert. And I think those two aspects point out how two people are affected differently by this. Because in one person, it's driven by fear, and the other is driven by preference, right? And so for those people who want to be at home just because it's their preference, this is nice. For the other folks that are struggling with mental illness, this is facilitating avoidance. It's the opposite of what's healthy for them. And there's going to be a lot of work that we're going to all have to do to help support these individuals reintegrate back into a situation that provokes a lot of those underlying anxieties.
Well, and that's exactly, just to chime in with what Jeremy said, you know, I have a lot of students who are now kind of starting to get more anxious about the idea that they have to be back into school probably next year. And they kind of felt like this was a break from their worries and stress and social anxiety. And so they're already starting to like, oh no, now I got to get back into it. And, or can I convince my parents somehow that this is something I should do long-term? And so I think these are the questions that we as providers are going to be asked for by parents is, geez, they've really excelled this past year. Does it make sense to send them back? So I think there's going to be changes maybe even within the academic school systems to allow maybe some of these more different educational options in the future.
Well, I've seen with a lot of youth that they were so excited to be home in the beginning. This is awesome. You know, I have my own schedule, I can sleep in. And then it started going a little wonky. You know, the social isolation, video games, social media just became even a bigger part of their lives. And something I've been excited to see is little groups popping up. I know in Park City, we have this group that's going out snowshoeing just for connections. You know, just I see therapists, you know, are taking their clients out on the trail to, you know, do talk therapy outside, or have, you know, we have somebody in town that has a van that she takes around to meet with people. So I think that I think we have an opportunity to get much more creative about a therapeutic approach, off the couch, moving, doing different things. And that excites me. I see that starting.
Yeah, for my kids, it went wonky when they realized that there's no such thing as a snow day anymore. That, you know, school doesn't shut down. You can do
Yep.
school out of the house.
And there's been a lot of dropout in school. Actually, there's a lot of kids that aren't attending as much as they should be, aren't engaged. So there's going to be gaps in cognitively in learning for kids. And, you know, I have to think about teachers and how much they need our support in this time, because this has been traumatic for them, and they're going to go back in the classroom, and it's going to be even more of a challenge to meet the needs of all the students, because they're going to be in even different places.
So Kathy, we have time for one more question.
Right.
And one question came in that hasn't been answered in the chat, so I would like to ask that one. Sean Nickerson is asking, regarding ketamine treatments, Jeremy, can you please discuss the effectiveness of IV ketamine versus ES ketamine? Follow up. Are there any suggestions on overcoming the insurance challenges encountered in IV ketamine?
Great question. And I know Dr. Melissa and other folks on the panel could have some information on this as well. We don't have any good head-to-head trials comparing the IV form to the intranasal form. That's the S-ketamine. That's the one that's been approved by Janssen, called Spravato. That's the one that is FDA approved. There's no head-to-head data. When you look at the actual studies and the effect sizes in the studies, it appears that the IV might work a little bit better, but we don't know for sure. And there's good data on the nasal form. And what I counsel patients on is go for the thing that's going to be least expensive for you. You know, that said, there still are insurance challenges with both. IV right now, the biggest challenge is the fact that because there's an FDA approved form of the intranasal, most insurance companies say, well, we're not going to cover this non-FDA approved form, even though the out-of-pocket cost to patients oftentimes ends up being about the same. Just speaking to patients about insurance companies, my biggest recommendation is to call the insurance company directly. If you are part of a group, talk to your HR department, have them call the insurance company. Most insurances, when they figure out and they look at this, I've actually spoken to 3 pharmaceutical and therapeutic committees. These are the committees for insurance companies that determine whether or not they're going to cover treatment. When we go and actually present this data, and they actually look at it really closely, a lot of them are willing to look into doing it. So a lot of it's just misinformation. But I think when we educate these insurance companies, especially now that we have this S-ketamine, this approved version, pushing insurance companies to work with clinics on that, I think is really, really important. There's still a lot of kickback. Insurance companies oftentimes try to not pay for things, as you guys are all well aware of. But I have found that me calling an insurance company and advocating for a patient versus a patient calling directly has different weight, and they love to hear from patients about their own experiences. So those are my thoughts. I'm sure other folks may have some more thoughts as well.
Well, I would reiterate being the squeaky wheel, because that's, you just got to keep calling them. I write lots of letters, a lot of letters, and we call, and you just got to have to keep contact them and say, okay, well, we're still not, a month later, we did something different. It's still not effective. So, get on the call, and insurance companies are probably more likely to be willing to pay for some of these services if the patient calls, from my experience. If they're the squeaky wheel, if they say, lay out the reasons for why this is important, in addition to our letters of support. But I think, the consumerism, there's power in consumerism, and they don't necessarily want to lose business. And so be a squeaky wheel, advocate for yourself and in your family is usually what I would recommend.
Thank you. Yes, the big theme here is insurance. So we'll see how that unfolds in the next couple of years. We are at the top of the hour, and we could go on for hours, I think, with this panel, and perhaps we'll have an opportunity to bring some of you back and do another program with Connect, because I found this so interesting. Thank you. I know Betty has some things she wants to address before we close out this meeting. And I want to do a big shout out to Betty before we're done. She has put this entire event together with such dedication and enthusiasm, and it just has been seamless because of you. Thank you.
Such kind words. Thank you, Kathy. It took me a second. I needed to let them sink in. And I have to also give a shout out to the entire Connect Summit County team who, for the last 3 weeks, it's been all hands on deck. And I just really, really appreciate the collaboration of my team members. So we are about to close this out, and I too want to thank our panelists personally. I feel like I could maybe be your case study for the continuum of care, just, throwing that out there. But really and truly, thank you all so much for being here and for lending your time and your expertise and your voice to Connect Summit County. I would like to just take a quick second to share with all of you the resources that you can actually reach out to with Connect Summit County. We have peer navigation services, and they are free of charge to any community member. These peer navigation services, they are just that. The people on the other end of the line it's a peer, someone who either speaks English or Spanish, who will listen, right? First of all, they're going to listen to what's happening in your life. And then they are going to look at all of the resources in Summit County and help connect you to the resources that may actually work for you. So please reach out to our peer navigation services. Linda and Yasmith are ready and willing to point you to resources. And in Summit and Wasatch counties, we now have a mobile crisis outreach team. This is crisis management. If you call a crisis line in Summit County or Wasatch County, including 911, you can request the mobile crisis outreach team to respond to your call. So a little different than our peer navigation line, which is a non-crisis line and really is more about directing you toward resources. So I'll leave that up. So if you want to take notes and write that stuff down, you're welcome to, or I can email it to you as well. If you, excuse me, I also want to just let everyone know that Dr. Kendrick is actually doing a 1-hour session on ketamine with the CATS Amsterdam Foundation Provider Education Series on March 10th. And you can go to connectsummitcounty.org to register for that if you're a provider in Summit County. And we would love to have you join us to dive deeper into that subject. Thank you so much for attending today's event. Wow. You know, there were over 40 people on this event, and we appreciate all of you so much for showing up and for being part of this conversation. There is a link in our chat to a post-event survey. We want to know how we did, and we want honest feedback, and we want to know if this was helpful, and if you learned something new about what's available in our community, and we just want to know how we did. So please take 60 seconds to complete that survey. And we also just want to highlight that all of our events and programming are free to the public. And we can only do that because we have the support of our community, because Park City Realtors Philanthropic Foundation chose to sponsor this event, because of donations from our community, $1, $2, $3, $200, whatever, right? And we would love to invite you to become part of our philanthropic mission to ensure that everyone in our community can talk about mental health, and can feel safe and like they know where to turn. So with that, thank you all so much for joining us. And we look forward to seeing many of you again at our 2 p.m. session about mental health and affordable housing. Thanks again, and take good care. If I can turn off the Zoom.